Welcome to Connected Paediatrics, the podcast that connects you with the evidence. Hello and welcome to this episode of Connected Paediatrics. My name is Mike Marinas. I am your host and chiropractor here on the podcast. Today, very happy to be able to have Biokineticist Chineldi Pienaar with me. How are you doing?
Good, and you, Mike?
I'm not too bad. It's always fun to be able to hang out with the people that we speak to on the phone from time to time going, please can you see this patient?
It's really cool to come and visit you without a little baby.
Yes, that's it, yeah. You generally hang out here with babies, hey? Yeah. So here we are sitting babyless, but we want to be talking today about Sever's disease, most sort of upfront, because this is one of those things that as a chiropractor I come across from time to time. I come across these young athletes that all of a sudden have this devastating blow given to them, and they've been to whoever professional they've been to, and generally the story that I get is they've been told no more. No more of the sport that you love, no more at this time of your life where you are about to develop all the abilities that you're going to use to be able to take forward with this sport. If it's going to become your life potentially or become a big part of your life, now you have to can it. So what I have is parents coming in here going, it can't be the case. And I remember the first time I dealt with something like that, and I worked here and I did what I could, and then I was like, okay, but I think we need a little more. And I remember contacting you, sending the child through to you, and it was amazing. Because all of a sudden this kid was getting back to sport again. I was just trying to hold them together, but through what you were doing, you were literally bringing them back into playing again. So that's why I was like, no, I have to have you on, and we need to talk about what it is that you're doing. So we're going to start off just talking about Severs in sort of basic terms. What are we talking about when we talk Severs?
So it's the inflammation of the growth plate, and it's on the heel where the symptoms occur. And what happens, it often happens in the growth spurt. So that's where it starts being niggly and sore, and the inflammation happens because the growth happens at different rates. Bones and tendons and muscles grow at different rates, and sometimes through these growth spurts, then we see that the muscles and the tendons are so tight because of the big growth spurt and the bone growth that it really pulls on that growth plate, it inflames it, and it's quite angry. And that's why it's so much more common in the guys that are active, because they use those muscles so much more. So they've got tighter muscles, tighter tendons.
Sure, this is not a couch potato problem, right?
Not often, not something we'll see, and that's why it's so devastating. It's the little boys or girls who really want to do sport, and now they get this breaking news that, sorry, the only treatment that the doctor said that's working is rest. And luckily we've found better ways so that these poor kids aren't so sad for so long.
I mean, and it's the same as any of the new research I read. Bed rest, it's not about that. It's about selective rest of selective pieces of anatomy to allow them to be able to get back into the swing of things.
So the word is optimal loading, and in rehab circles, that's our big new word. And I think it's so applicable to most phases of rehab now. If you can, the load has to start quickly, but it has to be right. And with these kids, that's what works perfectly. So you can manage their load, because it's often, Severs is linked to an overuse injury. It's these kids that just do too much, and they're often the one that can run in the athletic team, do the jump, they play rugby and they play cricket because they're the sporty one that's really good at it, and we see it in them. And they have just overused an area that's quite tender. So if we manage their load and we take them out of a bit of jumping or a bit of kicking, and we rather say, well, you can play a little bit of rugby, but in short bouts, we found that we actually don't inflame the growth plate as much, and they don't feel that irritated, but they still feel like they're part of the team and they're there on the field, and they don't feel like they've missed a whole year of sport, which really is horrible to tell a 13 or 14-year-old boy.
I mean, that's the crux of this, because that's the age group we're looking at. And we're looking at when you start to get strong, you start to now want to be able to mold this strength to be able to develop all sorts of dynamic, like almost even like brain plans around movement and that kind of thing. And it's right here that the old, as you say, the old idea was to just say, bed rest. Because, and I think what they used to look at is they said, well, it's a piece of developing anatomy, it's a growth plate. So what we need to do is wait until that's done, and then you can go and do your stuff. And the problem is by that stage, you've missed an athlete. You've missed a whole athlete.
you've also deconditioned an athlete that was well conditioned because you didn't do anything for a whole year.
Yeah.
And that's a big problem, because now we find that these guys were well conditioned and they were moving, and they actually turn into couch potatoes because for that year of rest they've stayed out of activity.
Yeah.
So what's important is to modify the activity and to work on the areas around it, because these guys are going through a growth spurt. Their core's a little bit dodgy, they're not using their glutes properly, their proprioception's not as good as it should be. Put them on a year of rest and they come back deconditioned and really prone to injury. But put them on a program for a year that's managing their load, that's focusing on their core, that's really looking after their proprioception. They return to sport when they're better, being a better conditioned athlete than they were when they went on rest. And that's ideal, because then we still have a motivated, talented athlete going back to sport, instead of putting someone on the couch for a year, returning to sport, seeing that you're actually not as good at this as you used to be, and you feel like you've lost a little bit of your spark there, and they often stop playing sport because of it, because they just think a year's been too long, it's hard to go back now, I'm just gonna play games and
because I'm seeing two sides to this. I'm seeing a physical deconditioning side, which is then so hard. I mean, we all know if you skip gym for 2 weeks, all your gains are lost and they're all gone. But now you're looking at a kid that's growing, that's not just putting these gains in terms of like getting themselves conditioned. This is conditioning that's supposed to then last going forward. But I think the second thing, which is really interesting that you brought up now, was the fact that they will move away from the sport. So there's a psychological side to this as well, that little athlete might become broken in a psychological way of going, well, I'm not going back to sport because what if something else happens? I'm not putting myself through all of that because what if I do that and I get my hopes up again and then I just have to be bashed around again?
And that's important with the age group we're working at. They're quite a delicate age
These
group.
are emo people.
They really are. And their friends' opinion really matter. What their coach thinks really matters. And if that starts becoming something that they're insecure about, they move away from it often. So you want to keep this child motivated and moving, and as much part of it as they can be. As much part of it as bringing water to your team, being there on the field, doing modified core stuff while they are running, but being involved, being there, because like I said, by the time they return to sport, they don't feel like an outsider in their team, they don't feel like they've lost conditioning, they're still very much a part of that group. It also helped us with compliance. If you tell these really active youngsters, listen, you can't do anything, I find that they just don't listen to us anyway, because that's not what they want to hear. They rather go out and still keep doing what they did. Then they get really sore, and then they're a massive risk for a stress fracture. And that we really do have to keep them out for them. Then we're sitting with a whole different treatment approach, which is much harder to manage than Sever's. So you rather want to manage the athlete that you have, knowing their abilities, knowing what they'll listen to, how much can we give this person, how much must we take away. Otherwise, they don't listen. I've had guys who've been in moon boots or casts for 6 months or in and out of the cast for 6 months with no activity. After that, you're sitting with a very deconditioned little athlete who has to retrain so many things. So you really want to avoid going there. Super
difficult. I think also, like you were saying, manage the patient. I would say as well, maybe also to manage the parent, because I think in a lot of situations you have both sides of it. So you'll have a parent that goes, no, you're finished with this now. Where you go, whoa, no, we're not. Potentially, we're not finished with this. And then you also have the other side where you have the parent going, no, he can still play. Carry on, because if he misses this, he's going to have to, you just patch him up, carry on playing. So I think maybe, managing all aspects here. You're bringing up such stuff that I hadn't thought about.
This is
why I invite clever people onto this podcast so I can learn.
It's about the education of both parties. And coaches at schools, those ones are the dangerous ones. You have to have all the parties involved, really understanding what is this condition? Why is this child resting? Especially if it's an important child in their team, which it really often is. I've often seen it's the star guy, the coach wants him back, and like I said, he's used him in the athletics team, the rugby team, the soccer team. He's the all-rounder because he's the talented one, and that's why he's overloaded. That's why the symptoms are angry. And to explain to the both groups involved that if we could manage this child's load, they could return to sport really well afterwards. But it really takes education of the parent, the coach, and the athlete involved. They tend to listen more to their coach than to their parents or me, unfortunately. So that's often someone that I give a call, because if he understands where we're at, then at least we can move forward.
So I think we're covering all the bases here. Everyone has to be involved. Everyone has to have a good understanding of what's happening with this child and how to best go forward with them. So let's start off with my side. So I get a kid that comes in, we have a look. It's a traction issue that's going on, tractioning on a growth plate. My first and most important things for that child is to make sure that the way they're bearing load through their joints is working properly. I want to make sure that there's no restriction to movement around the joint complexes, so that we're not getting anything that's putting an unfair load, let's say, on one side or the other. I fix all of that up. I get to the point where I'm quite happy that that's going on. Yet I know that because this is like a top performing little athlete, putting them passively into the right place, maybe not enough with them. So now I need to send them off to you. What does your treatment look like for a kid that arrives at your office with Severs? What are you going to be doing with them?
We still have to realize that everyone is very individualized. Sure. They hit this injury at different ages, and that makes a big difference. So I always assessed all their posture, all their strength, all their function, because I see different strength deficits. It's not a clear-cut strength deficit of plantar dorsiflexion being a ratio deficit, or a knee, hamstring, quad that's a ratio deficit. These kids present with different deficits from where they're at. So we will assess each kid individually, have a look at the way they move. Their posture is still important in this phase, and that's where we pick up the stuff that you guys can fix. A leg length discrepancy is
we were
terrible.
saying off air now,
for a child with Severs, because they'll automatically load differently and be on one toe more than they should be, which is what we don't want.
Sure.
Bad feet, unfortunately, is a terrible red flag for it. Pronation, supination, high arches, flat arches.
Okay, so anything really that changes.
So they're all different, and not all of them, it's not a clear cut. Not all of them come in with a high arch. Not all of them come in with a short Achilles. So we do a very individualized assessment. Girls and boys look different with this too. They're in different phases of puberty, and their bodies are quite different at that phase. So we'll assess how their core is working, we'll assess how they move in function, and then assess the load that they're currently doing, because that is the biggest thing. How much load are you taking at the moment? And that's what we have to try and manage throughout the week. Just maybe changing one session to a pull session instead of a land session can make such a big difference, that they rest that tendon or that muscle for the right amount of time, that there's no pull on the growth plate. Where in the other phases they really are super inflamed, and we have to do rest all land activities. You can go into the water, you can do some core stuff, and you can do some upper body stuff. But I've never told anyone to do nothing. So we've just really managed to say core is important. Can you see we've tested your core? And that's why we do test them in core position, so we can show them why that will be important. The more educated your patient leaves you, the more compliant they'll be to our program. So that education, that first assessment for me is very important.
So important, huh?
And then we'll assess what we've seen. So very often I do address glute and core stabilizers as quite a big part of their program. Like I said, I think it's more the age that they at than the disease itself. They generally have a little bit of a weaker core. They're all arms and legs almost at that phase. They've grown so quickly, and their muscles just haven't kept up. So we do core and glutes stabilizers, and a lot of proprioception. Like I said, that's a closed chain. It won't upset the growth plate. People go, you mustn't bear any weight. So that's not really true. If you do an isometric or a closed chain exercise with them, there's no load on the growth plate. You're keeping them still, and their calves working, but the muscles in their foot's working, and they're not getting really lazy there. Stretching of the Achilles is one of the things that's actually quite straightforward, but it's not always the right thing to do, because if they're quite inflamed and you put them in an aggressive stretch, that's not really nice. So you really want to see where they're comfortable and what they can do. And between 9 and 15 for boys, because that's the common age, you've seen guys who are really little and really small, and I've seen guys who are almost fully grown and wear a size 13 shoe. So it's from a little boy to a really big boy. And that's why your approach has to be very individualized with these guys. You can't go, I have a Sever's protocol and we follow.
I love that, because that's what I'm getting out of what you're saying, is Severs is an outcome. But the outcome doesn't have to be from a certain set of events. There can be many events that come out with this kind of traction apophysitis that is happening with these guys, just simply because that's what it's landing into. You could have something like that landing into an Osgood-Schlatter's, where they could be pulling onto the tibial tubercle. But then again, you would have to go back and reassess all of the muscles involved. Where's the weakness? Where's the traction? Is there a Q angle change? Is there all of these bits and pieces? Which is fantastic, because it's not come in, lie down, it's a Sever's problem, good. These are the 3 things we're going to do. Oh, it's not working, well, sorry for you. And it's amazing how things have moved on that way, to be able to go, right, there's so many bits and pieces that we have to look at inside here. And then the other thing, which I really love what you were talking about, is that it almost sounds to me like you're trying to find a safe space to be able to load that area without irritating. So keep everything else moving and just bring it right down to the point where I'm not irritating that thing specifically, but I'm allowing everything else to move.
Yes, and you want to be progressive with that. You don't want to stay in that same boring routine for them for too long. If they've had no pain in a certain movement for more than 2 weeks, I'll move them to something else and see if in that movement they also have no pain. Because often they can take a lot more load than we think once we start managing the outside extrinsic factors of jumping and pivoting and cutting. Then we can see that they can actually go into a calf raise, even though that could be seen as a loaded exercise.
Sure.
The load is important there, and it's helping them to strengthen up a complex that's weak in the first place, so they could do it and they could still not have any pain. Some guys are quite angry in that place, they don't do it, but that's why you have to measure firstly, which we like to do, and assess, and then progress from there and keep measuring and showing the patient this. And remember, when you started, you couldn't even stand on your one leg without it being sore. You see now we're on a one leg and we're doing a calf raise and your glutes activated and you're still not sore. So some guys can even run for a while.
You forget what you arrived in that office with, and then as you make these little gains all the time, you start to go, well, it's normal, but then you kind of have to be shown, hey man, when you arrived in the office, you can hardly do this, and now look what you do.
We do it more for the parents than the kids. They're the ones who don't always believe that they're better, or that there's been no progress whatsoever because he's still sore. Yeah. But what we see is sore becomes more relative, and what I always tell them is it's going to be fewer and further apart, probably not completely gone, but you won't be sore every day anymore. Maybe you'll see, oh, I did that and that made me sore. And that's so important to tell us, because then we know that was overloading it. And we'll pull that from your program, not say, okay, now stop completely.
Sure.
So that the load management concept there, I think that's the most success we'll have managing someone in that age group, like I said, for compliance too. If you just manage their load, not stop their load, then they tend to be more compliant. They go, okay, she hasn't said I can't do anything.
Oh, the can't word. Oh, the can't word, yeah.
And that these parents who think they're going to be the next Springbok, for them it's a devastating blow, because they're living out all their dreams through this little child. So we have to really manage expectations properly and keep measuring. If we see no success and they're really angry, I'll send them for an x-ray to see if it's not a stress fracture. But it hasn't. I really haven't come across that often. That's in the severe cases that they get the stress fractures. Those are the guys who didn't listen for 3 or 4 months when the doctor told them to rest, and they kept pushing, and that developed into a stress fracture. And like I said, that of course is completely different treatment.
The management changes completely for that.
So we could rather manage them well in that little inflamed bit than get them into that very angry bit where we have to say, okay, listen buddy, now sorry, now you can't do anything, now you're going to do some elastic stuff with your upper body and maybe activate your glutes, but you're going to sit down now, which is horrible, and we really don't want to get there.
Yeah, absolutely. And the idea with this management is to manage them back into their sport again. And as you were saying in the beginning, which I didn't really think about, it's to manage them back into their sport and to mitigate the fact that they might get more injuries had they deconditioned over the other period of time where they were supposedly out the whole time.
As I say, it's a crucial phase in their growth, and they often do develop deficits from there. If we look at the athletes eventually with different injuries, you'll see it happen when they started hitting puberty and their body changed so much. So that's already an area. And if you really condition them well, they return to sport better than they were before the terrible condition was diagnosed, which wasn't really that bad. They have a better understanding of their bodies. They turn into better athletes, and that's what we want, a well-rounded individual one day, not someone who's being groomed for this or that.
Yes.
Telling them that, listen, these things are in general important for your kid. We want them to be in balance, be able to move between different sports if that is what they would want to do.
Because there's life after your sport as well. You're still going to have a job. You're going to have to lift your kids up into a bath. As we know, you're going to have to be lifting kids all over the place. That injured site is going to have to last you for a long time. And we don't want that mismanaged to then land you with another severe injury, which is then now going to hamstring you from further sports and further things.
And a sore lower back because you've altered your gait. They tend to walk on their toes. Or a sore hip because now you've shifted the load from the one side to the other side. The injured site settles down and their symptoms settle down, but then they've learned to do something in a certain mechanical way, and their biomechanics are bad. And they stay in the bad biomechanics. Sure,
they work. The mechanics work because it's a compensation.
And then I ask them why they walk on their toes when they are 18, and I see them and their mom says, but when they're 14, they had Severs for a year, but we rested him and it's fine now. And then I go, okay, well, maybe that's why you walk on your toes. Maybe
fine
we
is
should
a
have done
very relative term. Yeah, and it is. It's a relative term because we think that things are fixed up, but you can have these lingering things like that. Like we were saying, the leg length inequalities, those kind of things that are going to linger through, and then be things that are going to irritate you further on in life as well. Now we spoke, and I just want to end on this. We spoke a little bit before we started. If something, and I think we've just covered a little bit of it now, but if something like Severs is not attended to, what is the outcome?
So I think the symptoms around the heel, I don't see those, so I don't know what happened to them, but what I would think is that the symptoms around the heel would settle. But like I said, it would settle over a time where the athlete was inactive.
Sure.
And what happens then is they tend to decondition different places in their body too, because they haven't used their ankle joint, they haven't used their core, and the risk is they go back to sport wanting to be the way they were when they started, because no one managed them in between. They return to sport at the level they stopped sport at, and they're a massive risk for another injury. So the biggest risk for me is not the growth plate itself in your general population, it's the way they'll return to sport after rest, making them a higher risk. And then of course, like I said, the guys who push through and don't listen, they're a big risk of developing a stress fracture, and that is a really horrible thing to get when you're that young, because then we really do have to change the treatment management.
Okay, so our takeaways from this fantastic chat that we've had, our takeaways here are that it's not bed rest, that's old. It is limited and it's optimal loading. You were saying the buzzword is?
Optimal loading, that's what we're looking at.
That's what we're looking at. We're trying to keep them from becoming deconditioned through this period of this development that they're having. We want them to be in as least pain as possible. We want to manage everyone that's involved in this situation, because there are extraneous factors that are going to put weird thoughts in people's heads, and then they're going to think, okay, well, maybe I need to do this or I need to do that. We want to be almost very evidence-based as we move forward with this kind of thing, and then also have the bigger picture in mind to go, there's a lot of life to live after this thing. So we don't want you to have another big injury. We want you to have the best time you can now, but it might be to slow down now, load things properly, and we move you back into sport. And remember that you're not, I say this, and as I say this, I picture myself being off gym for 3 months and arriving back and looking at those same weights and going, I got this. And then arriving back at work the next day saying, I can't flex my arm. And what's this weird pain inside my elbow? Because I thought that I could move straight back in there, and it's not about that. It's almost like an optimal loading for reintroduction, reintroducing yourself back into sport. Cool. Is there anything that we haven't covered that we should have talked about?
No, I think if you can manage the load, the athlete and the parents are happy, but it's quite challenging. They tend to still want to do too much, and those are the guys that you'll see with it won't settle down, and then managing the expectations of everyone involved of how long this could take, and then why it would be important. But if you get the loading right with this thing, it really doesn't get into anything worse. And like I said, we have a happy, healthy athlete returning the year after in a good space.
Wonderful. Chineldi Pienaar, biokineticist, and all-around good person. It was wonderful to have you on the show. Thank you very, very much for coming through and explaining this to us. I learned a lot. That's why I do this stuff, because I end up learning a lot. And then on the off chance someone else out there might have my problems and might want to learn one or two things about this as well. So thank you for coming in and covering Severs. I think we might cover a couple of other conditions as time goes on, because I think there's a big space for this. So thank you very much for coming through.
Cool, thanks Mike.